Very glad to give you an appreciation of one of my pet topics, which is LAA closure. In the context of gastrointestinal bleeding, it has a high relevance, but it also has relevance in other contexts. Now, atrial fibrillation, which is the reason why we would close left atrial appendage, is a very common thing. You see it, it's particularly remarkable that every fourth of us will have something going on with himself with atrial fibrillation, unless until they you get to that age, somebody is found to prevent it. Switzerland currently 60,000 patients recognized for atrial fibrillation, and this will grow with the aging of the population, maybe threefold in the next 30 years. Now, why would you close the left atrial appendage? That comes from quite surprising findings in 23 reports on autopsy, surgery, and TEE examinations that, yes, atrial fibrillation begets clots. So in non-anticoagulated patients with non-rheumatic, non-valvular usually, but that means non-rheumatic atrial fibrillation, 17% will have a clot. You have to do something against it. But then, of course, what is really remarkable is that of those 17% are distributed so that 94 of those 17%, 16% are in the left atrial appendage. So take the left atrial appendage away, what's remaining for a risk will never justify oral anticoagulation with its inherent risk of bleeding. So there is no reason mathematically to anticoagulate somebody without the left atrial appendage in atrial fibrillation. Now, does this also translate into the clinical results? Well, first of all, the proof that they are in the left atrial appendage was shown here in an echocardiogram in India, where they saw this clot in the left atrial appendage in a lady, 53-year-old, who then subsequently went on to have a stroke after her TE. So they went back to the TE and found out that they actually had filmed what was going on. Here you see the clot. A little bit later on this TE was already at the exit of the left atrial appendage. Then it fell out and then it was gone. And of course turned up in the head, at least in part. So the mechanism does exist. Usually it's more something like this here. You see at the orifice of the left atrial appendage, you see little clots breaking off the bigger clot in the left atrial appendage, which itself will not go away. It just will have fragments breaking off. Now, of course, one way would be, why don't you ablate atrial fibrillation? If you don't have atrial fibrillation, you don't need anticoagulation, and your left atrial appendage is of no importance. Now, as you can see, even with good results of atrial fibrillation ablation, here the very recent, this week actually, report on a European registry, still at 1 year, initially everybody is anticoagulated, but at 1 year still more than half of the patients are anticoagulated. So even the electrophysiologists don't really believe enough in their long-term success that they say this patient is out of atrial fibrillation, he will not need anticoagulation. You never know if there is a relapse. So if you're at 1 year still anticoagulated after a successful ablation, nobody's going to take you off. So even with ablation, which would be a non-pharmacological way of obviating the need for oral anticoagulation in atrial fibrillation, it's not working. So we have to go to other things, and this is, of course, taking the left atrial appendage out. And the surgeons have done it, but they never examined their patients because over the past 30 years they have closed left atrial appendage, but usually in conjunction with putting a metallic valve into the mitral position, which of course needed lifelong oral anticoagulation. So whether or not they had left atrial appendage, they needed anticoagulation. Nobody turned ahead. Only when an electrophysiologist, Michael Lesch, in the late 90s had the idea of maybe while he was about, ablating the left atrium, close the left atrial appendage at the same time with a block, that this would, even if the patient recurred, this would obviate the need for oral anticoagulation. The interest of the cardiologist woke up. And the first case was done by Horst Sievert to get in the presence of Michael Lesch on August 30, 2001. It was a very complex procedure, and since it has been abandoned, And I saw this, we tried this also in 2001, but it seemed to be that there must be an easier way, and so using the Amplatzer devices that we had used to close atrial septal defects and just plugging them into the left atrial appendage instead, having even in addition to a block this outside plate, which I then call pacifier principle, like the plate outside the toddler's mouth. And this was really an outpatient procedure, very easy to do, and no need for echo guidance, no need for general anesthesia, in contrast to the initial device. This then kind of made it attractive for us, and this is the world's first patient who was treated in June 15, 2002 with such a plug with a awake patient, and they made this procedure to be even an outpatient procedure, albeit it has certain risks, that's no doubt. This was a butcher who could not use oral anticoagulation in spite of his atrial fibrillation because of his profession. And he's now 12 or more years out, has never taken oral anticoagulation, still in atrial fibrillation. Of course, he's now retired, but has never had a problem. So here you see this pacifier in his left atrial appendage at the 1-year follow-up echo done by Hugo Salner. So we had these two devices in 2002, and later the same year a third device was, an American device was presented, a dedicated device, the Watchman, which then also gathered randomized data. Since we've had other devices that are used just in niche institutions, but the Amplatzer was later modified, adding some hooks, changing a little bit the shape. And finally, the last kid on the block is this one, but it's actually distributed between the Amplatzer and the Watchman worldwide, and the Amplatzer is the most commonly used device. The technique is quite simple, even for non-invasive cardiologists. You need a transeptal puncture unless you already have a PFO or an ASD to pass through. Here you see that we're puncturing right at the junction of the septum secundum and the septum primum, so we're basically creating a PFO in a patient who has a closed foramen ovale. Usually you puncture a little lower just to have a more straight access to the left atrial appendage. Then you go with a fairly large introducer. You make a picture of the left atrial appendage to give you the size of the device. There are several sizes to select. Then hopefully with the right size you implant this anchor, which has some hooks to retain it and keep it from embolizing, and then you produce this covering disc on the outside, and then you after releasing it, you make a final picture to make sure that you're in the right place. There's still some flow going into the left atrial appendage, but there will be a cover here of endocardium here on the outside, so this flow will go away. Now, with this device, there are about 1,000 patients worldwide who have been summarized, and you can see that the event of embolization, of embolic results was 2.3% per year, where you would expect, based on the CHAT score that they have, which gives you an estimate of how many ischemic events you expect per year. It's actually more than half of what you would expect, so it seems to work on the side of embolus reduction. Of course, this is not compared to warfarin, it's compared to no therapy. Now, is it going to work on the side of bleeding? Of course it works, because you don't need any anticoagulation, and everybody knows that if you don't anticoagulate, you have less bleeding than if you do. So there is also a very drastic reduction. Now, the other device, the Watchman device, has really had some very thorough workup with 2 randomized trials, the PROTECT AF and the PREVAIL trial, and a lot of registry data examining a lot of variation. Usually this device uses some anticoagulation for a few months after implantation, which we don't with our device. So for Jan Borowiczka, for bleeding patients, this device would be more difficult to use because of this predicament of needing, perhaps it doesn't need it, but it's what's recommended, use some anticoagulation. But they have now using 6 weeks of oral anticoagulation afterwards, but then stopping it, keeping the patients on aspirin, compared to warfarin all along, they've had some survival benefit, which is quite remarkable. Randomized trial with, at 60 months, 5 years, a significant survival benefit compared to warfarin. Of course, all these patients could take warfarin, but you can deduce that in those who cannot take warfarin, closing it with a device is certainly a good idea. Now, we don't have, with our device, we don't have randomized trials, but we have in those 1,000 patients also a follow-up of about that length, and you see that our mortality goes exactly along the line of the Watchman device. That's an indirect comparison, but it seems to be a class effect of closing versus warfarin rather than a device-specific effect. Now, looking at the mortality reduction of this device compared to warfarin, it's actually about twice as high than any mortality reduction that was proved in the randomized trials using non-vitamin K oral anticoagulants compared to warfarin. They also had some mortality benefit, but the one with the device seems to be on a larger scale. So it seems that even compared with new oral anticoagulants, you really have to think seriously about LAA closure instead of oral anticoagulants. And looking at the apixaban against warfarin trial, where you see this curve of systemic embolism with warfarin and a little lower with apixaban. Of course, if you have to choose between the two of them, you'd certainly choose apixaban over warfarin. But looking at our Bern data, you can see that our ACP patients go along the line of apixaban rather than along the line of warfarin. So for stroke reduction already, we seem to be better than warfarin and as good as the new oral anticoagulants, or at least one of them. And then, of course, you have the other side of the metal, bleeding. All the new oral anticoagulants still have a bleeding risk. Some, as Jan showed, even more than warfarin, some less. But there is a bleeding risk. Apixaban per year 2.1%, Dabigatran 3.1%, and rivaroxaban 3.6%. And of course, we don't use oral anticoagulants after our implantation. We use platelet inhibitors for a few months, and in some patients we stop everything. Our bleeding risk, of course, is much smaller. So it seems to be actually that we have to offer this to every patient with atrial fibrillation. We're not doing that yet. The guidelines don't recommend that yet, but looking at these data, mortality benefit, you have to do that. If the patient could choose to start on the day after implantation, they would all choose it. But of course, the day of implantation has an inherent risk of embolization, of pericardial effusion, air embolization, and so forth. So nobody wants to live the day of the intervention, which is a front-loaded risk. After that, the risk is very small. But it's the better choice than having oral anticoagulation with a new compound for the rest of their lives with an ever-increasing and yearly ongoing risk of bleeding. Now, what does it cost? If you look at this way of calculating it, I'm not sure if that's a valid way, but it was published in Circulation. Now, if you compare the cost of warfarin and you compare the cost of implanting a device at about $50,000, you can buy a year of quality adjusted life. So it is more expensive, but it only costs $50,000 to buy 1 year over warfarin. Now, if you use a novel oral anticoagulant, Dabigatran, for instance, you will cross the line only at $90,000. So you have to invest more money with a novel oral anticoagulant to have a better outcome than you have with the device. So it's even cheaper. It's not cheaper than warfarin. You have to pay a certain price, but you get a better outcome for a price that is better than if you switch on to a non-vitamin K oral anticoagulant. So I think we'll have to change our paradigm. We have to offer this seriously to every patient with atrial fibrillation, and gastroenterologists are clearly happy if they have an LAA occluder rather than oral anticoagulants, and so are nephrologists who have people on dialysis, which of course does not go well with oral anticoagulation either. Thank you.
Professor Meier, for this wonderful talk. I'm not so familiar with this device, so I have always the impression it could flood away. Is it possible? Or?
Yes, device embolization occurs in about 3%. Of course, that's probably going to be improved by technique. What always will be a certain risk is pericardial bleeding during the intervention. You're working on the outside wall. It's a very thin walled structure. So bleeding of about 3% will remain a risk. So the procedure is not risk-free, but including these risks, there is a mortality benefit already appearing after a few years, and it will grow because anticoagulation will add events, bleeding events, whereas the bad events with device closure after a few weeks or a few months there should be none.
Okay, thank you. Are there any other questions from the audience?